Thank you, Mrs. and Mr. Chairman. Good afternoon, everybody. First of all, let me thank the organizers of the meeting for inviting me in Pune. My first time in Pune, although not my first time in India, and I'm really happy to have had this opportunity. I added to the first slide, since I see that the program cover has the Tower of Pisa, and I'm not for Pisa, I put the Tower of Turin instead, for you to see some of the town where I come from. Now, I decided that to make this presentation a bit more involving, I would start and go through a case report. So let me present the case of a 60-year-old woman who came as an outpatient with type 2 diabetes known for 15 years. She had poor control. Her hemoglobin A1C was 78 millimoles or 9.3%. Also, hypertension was not well controlled, but she luckily had suffered no coronary disease nor a stroke. And 2 years before this examination, she had screening for retinopathy, and which revealed moderate non-proliferative retinopathy. But recently, she complained of visual problems when reading or sewing. These are her blood tests at her last examination. She had microalbuminuria. Creatinine was 1.93 millimoles. Cholesterol was also elevated. HDL cholesterol was 67 milligrams, and the LDL cholesterol 107, slightly above the target for diabetes. Triglyceride was also elevated. Patient was already on metformin 3 times a day, 500 milligrams, sitagliptin, pioglitazone, enalapril twice daily, aspirin 100 milligrams, and simvastatin 10 milligrams. Now, the first question I would like to ask you, what do you think was the worst mistake when this patient had been managed? Was it having been unable to control blood glucose, or having been unable to control blood pressure, not doing another follow-up fundus examination, or do you think all of these were equally bad? Can you show your hands, raise your hands if you want. Which one do you choose? Number 4? Yeah, I guess everybody thinks that something better should have been done. So let's go through these points one by one. First of all, the first two would be metabolic control and blood pressure control. Metabolic control, we are all familiar with the old data from the DCCT showing that if you maintain people on optimized intensive control rather than conventional control, then you reduce the incidence of neuroretinopathy on the left, or progression of already existent mild retinopathy on the right. Please, I stress the word mild. We are all familiar with the concept of a metabolic memory, because every year spent in good control accumulates as we put it aside in the bank as a good result to prevent complications. And this was also shown in type 2 diabetes by the UK PDS, which revealed that intensive control reduced the need for cataract extraction and progression of retinopathy at 12 years. However, this is true for primary prevention or slowing progression of existing retinopathy. This meta-analysis that was published a few years ago already, from all studies with type 2 diabetes, showed that new or worsening retinopathy can be prevented by good metabolic control, but once it gets retinopathy progresses towards needing photocoagulation, then we have no effect whatsoever of good metabolic control. And when it comes to preventing blindness, again, there is absolutely no effect of metabolic control. So retinopathy is something we have to prevent. We cannot stop it with good control. What we do if we intensify control is increase the rate of hypoglycemia. So that was also a result of that meta-analysis and other meta-analysis that followed. With reference to blood pressure control, hypertension per se is a cause of retinopathy. It causes lesions like cotton wool spots and hemorrhages. So the two retinopathies, hypertensive and diabetic, can get mixed up. However, again, the UK PDS showed that better control of blood pressure reduces incidence of retinopathy. In particular, risk of worsening diabetic retinopathy, risk of worsening of visual acuity, probably acting through diabetic macular edema, for a reduction from what we would consider higher levels, 154/87 to 144/82, but although these might be above target, they were the type of values that our patient had. The ACCORD study showed something slightly different. It showed that control could reduce progression of retinopathy, but antihypertensive therapy did not. This was basically because the starting levels of blood pressure in the ACCORD study were lower than in the UK PDS. So there is little point in reducing blood pressure further. However, I will skip this one, okay, because it's, I think, a lack of time. But coming back to metabolic control, the numbers needed to treat to prevent one microvascular event over 10 years is 20 patients over 10 years, and that reduces complications-free interval by a little more than a year. So what we are facing is a wide increase in the incidence of retinopathy. These are projections in the United States, saying that from 5.5 million in 2005, 16 million in the United States will have retinopathy, and from 1.2 to 3.4 million will have visual-threatening retinopathy. So the diabetologist does some screening, takes digital fundus photographs, and this is what he found. This was the right eye, and this the left eye. Now, my next question to you is, what do you think this was? Was it moderate, non-proliferative with non-center involving macular edema? Was it moderate, non-proliferative with center involving macular edema? Severe non-proliferative with macular edema, or severe proliferative with macular edema? Who is for 4? Raise their hands. Who is for 3? 2? Ooh, okay, and 1? So many hands stayed low. So we will just go quickly through the natural history of diabetic retinopathy, remembering that there is a preclinical stage followed by mild, moderate, and severe non-proliferative, then proliferative, then advanced diabetic eye disease. From moderate to proliferative and onwards, we can have a parallel development of maculopathy or diabetic macular edema. This is what the normal retina normally looks like, with the optic disc here, corresponding to the optic nerve, the fovea, the center of vision, and the macular area. Now, this is what the normal retina looks like, even in a patient with diabetes. This is what we would call it preclinical diabetic retinopathy, where we have no lesions, but probably have altered blood flow, probably changes in the function of the neuroretina already, and possibly histologic changes already. The first signs of retinopathy are then the microaneurysms, these tiny little dots, which are basically aneurysms of the capillaries. Then they progress to more extensive hemorrhages, then cotton wool spots, these white spots. So we get to moderate non-proliferative retinopathy when we have a combination of not many hemorrhages, red lesions, and white lesions like cotton wool spots. Then the other lesion we have is hard exudates, which is accumulation of lipids within the retina. Now, if we don't have too many hard exudates, together with some hemorrhages and possibly contour wall spots, we still have moderate non-proliferative retinopathy. But if hard exudates get into the center of vision in the macula, then you get the macular edema, which can be pericentral or involving the center of the fovea, which is a result of edema, accumulation of fluid in the inner layers of the retina, and the lipids accumulating on the borders of the lesion. So this is a non-center involving diabetic macular edema, and this is a center involving macular edema. The difference is quite obvious. And this is what we can see by optical coherence tomography, which makes a sort of histologic section of the retina and shows the accumulation of fluid. Another thing that happens in the diabetic retinopathy is the closure of capillaries leading to retinal ischemia. You can see some preparations here. The capillaries are rarefied and there is no oxygen getting to these parts of the retina. And this may lead to either ischemic maculopathy, which adds to transudated maculopathy, and the ischemic retina encroaches also on the part of the macula. But what ischemia does is going towards severe non-proliferative retinopathy or pre-proliferative retinopathy, which is manifested by many cotton wool spots, white spots here, many venous abnormalities like this beading of the caliber, formation of loops, reduplications, many intraretinal microvascular abnormalities or capillary dilatations, and then that all leads to proliferative retinopathy, where we have growth of new vessels that are trying to bring oxygen to the ischemic retina. The new vessels can bleed extensively, as in this case, and then form fibrous tissue which tracks on the retina and causes retinal detachment, as in this case here, leading eventually to new vessels arriving at on the iris, and this is rubeosis iridis, and this is the latest stage of advanced diabetic eye disease. So going back to our patient, now that you've seen all the stages of retinopathy, which do you think is the right diagnosis for our patient? Was it number 4, proliferative with macular edema? Definitely she had macular edema, you can remember, so we can rule out number 1. Was it non-proliferative or proliferative? You think? It's difficult to say. I can tell you it was non-proliferative still because there was no evidence of new vessels, but it was a quite severe non-proliferative case. So what would you do next? You're the diabetologist in charge. Would you stop oral agents and start 4 daily injections of insulin, basal bolus, because her blood glucose control was very poor? Would you increase oral agents? Then some other points, would you add fenofibrate? Or you would forget all this and send the patient straight to an ophthalmologist for urgent referral? So who would increase, who would go to insulin? Please raise your hands. Okay. Who would increase the dose of oral agents? Who would use fenofibrate? Right? And who would just send the patient to an ophthalmologist without worrying more about that? Okay. So there are some mixed opinions in here, which is nice. Now, tightening glycemic control in a situation like that might lead to early worsening of retinopathy, particularly because the severity of pre-proliferative retinopathy was quite marked. So by tightening blood glucose control, you further reduce blood flow in the retina. The retina is already very ischemic, so you can make things worse. That is only temporary, but it would not be recommended in this particular case. So tightening control is not the first course of action. Okay, we just skip this too. I mean, we come to fenofibrate. Fenofibrate was revealed in the field study, which was designed for a totally different outcome, to reduce progression of retinopathy to laser treatment. Both, you see, fenofibrate versus placebo, there was a 30% reduction for laser treatment for either maculopathy or proliferative retinopathy. Interestingly, fenofibrate was effective when patients already had retinopathy, but not in preventing the onset of retinopathy, which is quite different from the effect of good metabolic control. So fenofibrate worked independently also of its effect on blood lipids. So it seems to have a different mode of action from that of reducing lipids or whatever metabolic activity it has. Fenofibrate is not registered for use in retinopathy, however, except for Australia and New Zealand. The effect of fenofibrate was confirmed in the ACCORD study. That was fenofibrate versus placebo in patients who were already on statins, and led to a significant reduction in the progression of diabetic retinopathy in these patients. But it had no effect on visual function, however. Statins do not seem to have any significant effect per se on the progression of diabetic retinopathy. So this is about what to do medically, which is very little, unless probably adding fenofibrate would be interesting, but not enough. Now, we might want to prudentially stop one of the drugs that the patient was on. So that could be enalapril, aspirin, simvastatin, or pioglitazone. Which one would you stop? Number 1, enalapril. Number 2, aspirin. Number 3, simvastatin. Number 4, pioglitazone. Okay, big show of hands, very good. Now, enalapril probably might have some beneficial effects. Enalapril and ARBs and sartans might help retinopathy, not at this stage though. Aspirin, you might be afraid of the new vessels bleeding because of aspirin, but that is not the case. It has been proven by a randomized controlled trial of retinopathy, the early treatment of diabetic retinopathy study many years ago. It does not increase the rate of bleeding, so it can be used safely. So we don't need to stop it. Simvastatin, we saw that statins are probably not very active in this case, or not a threat. Pioglitazone, glitazones may have a double effect on retinopathy. For one thing, this is a work by Lloyd Aiello at the Joslin Clinic showing that maybe glitazones might reduce progression to proliferative retinopathy, so they might be useful in this respect. But because we all know that they cause fluid retention, they might be involved in producing diabetic macular edema, and there have been case reports, although anecdotal, where diabetic macular edema regressed spontaneously after stopping glitazones. This is also a study done on more patients, and that again showed reduced progression of retinopathy in patients who did not use glitazones than in those who did use glitazones. But however, a very recent, just publication by the ACCORD study, again ACCORD always gave us controversial answers to all our questions, but ACCORD showed no influence of glitazones on the progression of retinopathy or the progression of macular edema in the patients in the trial. So we may think that prudentially we might stop pioglitazone, but that is not strongly evidence-based. So at this point, we are back to our patient. What do you think the best treatment would be for her eyes? Do photocoagulation, do for the whole retina, panretinal, only in the macula, use intravitreal anti-VEGF agents, use laser and anti-VEGF, or just medical treatment? Anybody would only do medical treatment? Anybody thinks you can use anti-VEGF and photocoagulation? Only intravitreal agents, focal grid only, or panretinal and focal grid? Okay, just quickly go. Panretinal photocoagulation basically works because it burns the periphery of the retina, which is ischemic, and blocks the growth or makes blood vessels regress. But it basically ablates the retina, burns the retina. It's a destructive type of treatment. Focal laser works on whenever we can identify the leaking microaneurysms. They are burned by very tiny laser spots, resulting in the reduction of leakage and the reduction of macular thickness on OCT. Grid laser is a sort of massage of the retina in the center of the macula, not very effective. In fact, photocoagulation is very effective in preventing blindness, but destroys the retina, does not restore lost vision or very, very little lost vision. We don't exactly know how it works. It may have side effects because the burns may enlarge and peripheral vision goes and everything. And particularly in the macular area, it is not very effective. So now we have these anti-intravitreal agents. These are agents that are injected directly into the eye. We have either steroids or 3 at least anti-VEGF antibodies. They work because, as we said, VEGF levels increase inside the eye when you have proliferative retinopathy and when you have macular edema, because they specifically are the final effector to induce edema and to induce growth of new vessels. So if we manage to block VEGF, we can reduce these sight-threatening aspects. This is one of the many studies that have been done. I find it particularly interesting because it was a very elegant study, I think the RESTORE study. Patients with reduced visual acuity due to macular edema were randomized to 3 arms, receiving an anti-VEGF laser and a sham laser, an anti-VEGF agent and laser, or a sham injection and only laser. And this is what happened. After 1 year, the patients who received only laser did not worsen but did not progress, whereas the patients in blue who received only the anti-VEGF agent improved their vision, and the fact that they had also laser did not make any difference. So laser did not have any added benefit. Following up the patients for another 2 years showed that the patients who only had laser now could benefit from injections, and they started to improve. Those who had the injections to start with remained stable with the best visual acuity, and those who had both were sort of in between. So it seems that these agents, I mean, this is trial conditions, not real life conditions, but still these agents seem to work very well and better than laser, so much so that nowadays patients with diabetic macular edema, if they have no central involvement, they can still be treated by laser. But if they have central involvement with vision loss, they should go with anti-VEGF treatment, and without vision loss, they have to, it depends. So our patient went for anti-VEGF treatment. So at this point, the ophthalmologist comes back to you because you thought you got rid of a patient. You thought, well, I mean, it's the eye doctor's problem. It's not my problem anymore. But the eye doctor is worried because she says this patient has a high cardiovascular risk profile. She's diabetic. She has severe retinopathy. She has uncontrolled lipids, uncontrolled blood pressure, uncontrolled blood sugar. And can I safely give anti-VEGF agents to this patient, or you, diabetologist, should first put some things right? So do you think the ophthalmologist can use do the treatment immediately? Would you do at least an ECG, an echo stress, an echo Doppler study? Would you improve anti-hypertensive medication? Or do you think treatment is totally contraindicated because a patient has too much of a high of a cardiovascular risk? Who thinks one? Can we act immediately? Do we have to do some number 2? Number 3? Number 4? Okay, some. Now, patients with diabetic retinopathy are definitely at increased cardiovascular risk, and if if they're going to receive these agents, these are the effects of VEGF. VEGF promotes angiogenesis, endothelial cell integrity, also vascular tone, platelet homeostasis, and protect the kidney. If we block VEGF, as we do, for instance, with anti-cancer therapy, we have anti-angiogenic bevacizumab is one of the molecules that we also use for the eye. We compromise wound healing and tissue repair. We might increase hypertension. We might increase arterial thromboembolic events, cause cardiac dysfunction, and cause renal damage. So what happens? I mean, the adverse events in some of the registration trials did show some increasing hemorrhage, including central nervous system and cerebrovascular hemorrhage, and thromboembolic events, both arterial and venous, in these patients. Now, you might think that because we inject a little amount of anti-VEGF agent within the eye, we are not going to cause big systemic effects, but we are not so sure now. Mortality increased with patients receiving these doses of if they had diabetes. If they did not have diabetes, mortality was not affected. So I will leave you with one last doubt and one possible cause for discussion. If you want to ask if you make any questions, do you think, having seen all this, that this patient should be treated with intravitreal anti-VEGF agents? Do you think there is something you can do to further characterize the cardiovascular risk, or do you think you would not have the treatment at all because of the risk of cardiovascular events? The next is my thank you for your attention, but I go back to this for discussion.
Thank you, Professor Porta, for a wonderful master class in diabetic retinopathy. But the question is still not answered.
No.
I think there will be some takes on that. As an ophthalmologist, we are looking for anti-VEGF injections now almost for many of the diabetic patients with diabetic retinopathy. The problem is we cannot guarantee a vision improvement and the number of injections which would be required for each patient. So we are always concerned about the cardiac status or a history of stroke in these patients. But recent studies like RESTORE studies have proven that cardiovascular risk with anti-VEGFs are quite less. But still, physician opinion is always required. So I would like any other questions from the audience regarding this topic?
I think it's a difficult question. I personally think this patient is risking to lose her eyesight, definitely, so she should be treated and carefully monitored from the point of view of her eye condition. But what I wanted to remark is that once the diabetes specialist just had to remember that the patient needed to do regular screening for the eyes, and once they found some retinopathy, it was the ophthalmologist's business. Nowadays, it's coming back. The ball is back in the diabetologist's court, and you still have to do something about it. You cannot just forget your patient and think that, okay, I won't see, or I just keep checking blood glucose and not worrying about the rest. Cardiovascular profile becomes even more important.
Any questions, any further questions on this?
Diabetic retinopathy, is there only the vascular component, or is there any diabetic cranial neuropathy involving the second nerve?
Yeah, okay, there is a lot of new studies about changes in the neuroretina, regarding both some functional changes in the electroretinogram, I mean time, latency time, amplitude of the waves that you record, but nothing so consistent in the absence of retinopathy, before retinopathy. And there are also some, with OCT you can now measure the thickness of the different layers of the retina, and some of the inner layers of the retina might be a bit thinner, but that does not correlate, does not associate with the presence of retinopathy or the development of retinopathy in the following years. I mean, we just published a paper recently in Diabetes about that, and there is not much of a correlation.
Any role for metcobalamin, vitamin B12 or metcobalamin?
Okay, we tried. I mean, there is nothing that I am aware of about the role of vitamins, or there has been a trial on neuroprotective agents given by eye drops, and that was somatostatin or brimonidine, which is an anti-glaucoma drops that patients use normally for glaucoma, hypothesizing that these molecules could enter the eye even if you put them outside. But there was no significant result.
I would like to add a comment. Brimonidine was supposed to reduce the blood pressure, or not the blood pressure, the intraocular pressure, so that increases the perfusion.
Yeah.
And hereby it increases the oxygen supply. And that is the theory behind using the brimonidine molecule.
That's true. I mean, the rationale was really, those were really patients with no retinopathy or minimal retinopathy, TDRS less than 35, so very mild retinopathy. And so, I mean, of course, they had no glaucoma, no other problems with their eyes. But, and the outcome was really measuring these neuroretinal functions, not, but I agree with you that probably increased eye pressure would reduce blood flow, but also reduce oxygenation. Probably reducing systemic blood pressure might help with macular edema because it reduces hydrostatic pressure.
Any work going on stem cell therapy or retinal implant? Transplant, retinal transplant.
No. Not that I know, at least.
There is work going on stem cell therapy for diabetic retinopathy.
Thank you.
Some study. I mean, that's Maria Grant's group, I think, and
yeah, this is it's still in the initial pipeline. Yeah, for the retinal transplant by stem cells.
Very, very preliminary, anyway.
I just wanted to add, what is the role of fenofibrate? As we know, in field and anchor, it has proven to be effective in diabetic patients with retinopathy. But if patients has a normal lipid profile, then should an ophthalmologist start a fenofibrate on his own? Is it a possibility?
Yeah, I'm sorry, the role of
fenofibrate.
Fenofibrate. Okay, those trials seem to suggest that it is effective in reducing progression and reducing the need for laser for both macular edema and proliferative retinopathy. There's two trials agreeing on that, and they're two relatively big things. The only regulatory authorities that accepted fenofibrate for use in these patients were Australia and New Zealand. We tried to, I mean, the manufacturer tried to have that accepted also in Europe, but that was rejected by regulatory agencies, saying that they needed a new trial to. So we actually did propose a new trial together with a network of ophthalmologists. We applied to the European Union for a trial showing that if patients with incipient maculopathy, with focal macular edema that might progress to central macular edema, whether they would benefit from fenofibrate and therefore need less laser and particularly less intravitreal injections. But again, that was refused because the assessors said that we all know that fenofibrate works, so we don't need another trial. So they didn't talk to each other, I guess.
Thank you very much. Any other question? So we conclude the session. Thank you very much, Professor Porta, for your
Thank you.
wonderful lecture. We'll call the next